analyzed our urodynamic findings, what we can diagnose with urodynamic studies. So can you please just again give us some examples how the urodynamic findings here influence our surgical decision makings?
So people would say, gosh, I don't really need urodynamics to determine that this woman would be a good candidate for, say, a mid-urethral sling. I can do, she may seem like an index patient. I can do a cough stress test in the clinic. I will do my urinalysis. I will get my post-void residual, and then we'll be able, but that happens. And then patients sometimes don't have the best outcomes. And one of the things that is always a risk for patients is an outlet obstruction because that's the nature of any of our sling technology. And so, what I've brought forth to you is an example of how I can use a urodynamics and what appears to be an uncomplicated patient, an index patient, to actually counsel about what's going to happen after their surgery and what the risks really are. So this patient here has stress urinary incontinence. They have an abdominal leak point pressure that we can measure. They have hypermobility. But then when they go to do the pressure flow aspect of the study and they void, they're straining. They have an underactivity of their detrusor, even though they generate flow. I will be able to confidently tell this patient preoperatively what her risk is for having an outlet obstruction procedure. Would it change the type of surgery that I do? Highly unlikely that it might change me, but it might change if I'm going to do a mid-urethral sling versus an autologous sling that has an even higher opportunity for obstruction. But what it will do is absolutely allow me to best counsel that patient about what the next steps may be and to tell her her risk profile for an outlet obstruction procedure after we undergo this type of stress incontinence surgery. If we have patients that also, here I have one that has a very, very low leak point pressure. And so this patient, although she has stress urinary incontinence, because her leak point pressure is so low, I'm going to counsel her about an autologous sling. Now, she also has underactivity of her detrusor during the pressure flow. So if she's going to get an autologous sling, we're going to have a long discussion about expectations for outlet obstruction and potential need even for intermittent catheterization in the long term. And the same here, a patient that has a very, very low, almost gravitational leak point pressure. When we do sling technologies on these patients, they may be at very high risk for outlet obstruction. But again, I'm going to be able to differentiate. This patient is very highly likely in this situation to require an autologous fascial sling as opposed to mid-urethral technology.
Yeah, exactly, Melissa. I just want to open a parenthesis here and just mention about some literature findings. For example, in the studies, in the randomized controlled studies, they tried to assess the value of urodynamic studies. And in these studies, the physicians were not blinded to urodynamic findings. And actually, although all patients were allocated to receive mid-urethral synthetic slings. In some of them, the transobturator route was changed to retropubic route, and the retropubic route was changed to the transobturator route. So actually, the urodynamic findings changed the decision making, and also when physicians were not blinded, I mean, it is very likely that they arranged the tension of the sling according to the urodynamic findings. It's very clear that if you have a patient with signs of detrusor underactivity, you don't want to put a sling, in a like kind of tensioned way. So you would like to have a looser tension, looser sling placement. So like that, actually, we have to be very careful when we analyze the randomized control trials that claim to assess actually the value of urodynamic studies in the surgical decision making.
Well, one of the things that we got questions about that is always a question in my practice as well is when you have cases of recurrent urinary incontinence after surgery, like when you do urodynamics on those patients, what specific parameters do you prioritize to try to determine the cause of the failure or the recurrence of the urinary incontinence after surgery?
Recurrent urinary incontinence is actually is a difficult condition to treat, and for all the treatment options that we have, whatever you choose has less chance compared to the primary intervention. So any patient with a recurrent urinary incontinence, first of all, requires a very thorough assessment, starting with the pre-surgical findings. So if I have a patient myself, just after a failed surgery, I will go through her data from the beginning and try to understand, first of all, what I have done or I have forgotten to do in the clinical assessment, or if we forget to assess anything. Not every urinary incontinence after surgery is stress urinary incontinence. We may have urgency type of urinary incontinence, overflow urinary incontinence, or even fistula. So it's important to differentiate between different types of urinary incontinence after surgical failure. And obstruction is something that we have to rule out because it may be found together with urinary incontinence. Even in primary cases, we know that a certain amount or certain ratio of patients have bladder outflow obstruction concomitant with stress urinary incontinence. And of course, the physical examination, and if I did a sling, for example, the localization of the sling is important in the assessment. So I just basically try to understand and answer the question, why has my operation failed? So this is a question that I try to really answer. And again, the patient's expectations must be assessed again. So, what is the patient waiting to get from us? What is the quality of life of the patient? And in order to do that, of course, we have, of course, the urodynamic studies, but also some radiological tools like translabial ultrasound is, I think, very helpful after a sling surgery to locate the sling, and cystoscopy whenever I think is needed. And I think in recurrent stress urinary incontinence, it's a mandatory tool before proceeding with any other irreversible.
Especially if there's been mesh implanted. I agree that that's a mandatory tool. I was just wondering about now, when do you do you use video urodynamics? You mentioned that. Is that frequently employed, particularly in the patient with recurrent stress incontinence?
Yeah, exactly. I mean, if we have video aerodynamic study, I mean, the opportunity to perform it, I think the video aerodynamic study is the best choice here for the assessment of our patients with recurrent urinary incontinence. We mentioned in the beginning of our discussion about the intrinsic sphincteric deficiency, and I think this is important to diagnose because it's certainly going to change our behavior. And we also know that ISD is one of the main reasons of recurrence of failure of surgical treatment in female stress urinary incontinence. And with video aerodynamic studies, of course, it's also possible in an accurate way to diagnose the bladder outflow obstruction as well if it coexists with recurrent urinary incontinence.
Yeah, and I agree, and this is oftentimes I'm very, aggressive, I think, about making sure that if we have outflow obstruction, after a stress incontinence procedure, that it gets addressed as early as feasible, as long as that is the shared decision with the patient. Because in the end, what's really important, of course, is the patient counseling and their expectations, right? And so, what are some things that you do as far as considerations for patient counseling?
Yeah, we have to understand the patient's expectations very well. So, what does the patient want from us? And there are so many differences from patient to patient, depending on their social background, cultural background.
And I have some patients that want to continue to catheterize for a good period of time if they have outlet obstruction, that they're not interested in another surgical intervention, right? So it's always a shared decision making between the patient, then their expectations, and what, I would do if I was given a paternalistic view of their situation.
Yeah, exactly. And on the contrary, there may be another patient who doesn't want a clean intermittent catheterization or any type of catheterization, and who prefers to be continent rather than, incontinent, rather than being catheterized. So we have to really make a shared decision making here. And understand the patient expectations. Of course, after understanding the pathophysiology, we have to share the pathophysiology with our patients. The good part with urodynamic studies is actually our patient counseling is changing. So we sometimes ignore the importance of patient counseling, but urodynamic studies enable us to discuss with our patients the real reason of their problem. And my patients, and I'm sure that it's everywhere in the world, patients like to know the real problem, the hidden problem, what is the mechanism of their urinary incontinence. So you can really increase the patient satisfaction with the findings of your urodynamic studies. And of course, the final decision is always related to surgeon's experience, which so we cannot ignore the importance of surgeon's experience here. And the comorbidities of our patients are also important. We have to consider the comorbidities of our patients, especially in the elderly population. So patient counseling is, I think, best done under the light of our urodynamic findings here in that patient group.
And it's true, when we're looking, and there were questions about interpreting urodynamics in older women, because it's a very prominent issue that we have, and what kind of age related changes, might occur with bladder function. And I just wanted to bring back up the fact of how valuable the urodynamics can be to look for detrusor underactivity. And I brought up another tracing here where a patient is straining to void, they have an underactive detrusor and they have stress incontinence. And so having that information up front to give you the best counseling is really one of the best practices that we have of when we think about how we're going to use this urodynamic information. And you've already kind of inferred it, but tell me more about how you really incorporate this into the shared decision making with patients when you look at treatment options, like maybe when you look at even special populations.
Yeah. If in the elderly population, especially, we know that the many of our treatment modalities can be successfully applied also in the elderly population. The real problem is the comorbidities. More than being an elderly, the comorbidities, especially obesity, for example, is an important factor in our decision making.